Good morning, everybody, and a very warm welcome to yet a webinar brought to you by SARS this morning. Very nice to have so many people already in the webinar room. Just to let you know that we received more than 1,200 registrants for this webinar this morning. It's an absolute pleasure for SARS to bring you this webinar this morning. My name is Niels Norkier. I am the CEO of SARS. SARS is the South African Institute of Occupational Safety and Health, which is a SAQA recognized professional body in South Africa to register health and safety practitioners in South Africa. We currently have 3 professional designations registered on the NQF, which is in terms of the NQF Act, namely technical member, graduate member, and chartered member. Currently, SARS is the largest health and safety professional body in Africa with more than 16,000 members. Right, with regards to this webinar this morning, I'm sure you're all familiar and know of the massive exhibit that takes place every second year in South Africa called Electra Mining Africa. This morning, this webinar is brought to you by SARS under the umbrella of Electra Mining Africa Connect, with a slogan that says it's more than a show. Although not live this year due to the COVID-19 pandemic, and to maintain the spirit of the show, this week Electra Mining will be hosting Electra Mining Africa 2020 Connect. This week, industry players will unite in celebrating of Electra Mining Africa through participation in the live industry webinar series and exhibitor product showcases. For the past 48 years, Electra Mining has been at the forefront of delivering the latest products, services, and innovations to captive and respective audience, bringing together industry from mining, manufacturing, electrical power, transport, and new for 2020, automation. It is the largest show of its kind on the African continent and highly anticipated by all. This makes the cancellation of the 2020 edition of Electra Mining as a result of the global COVID-19 pandemic all the more disappointing. Electra Mining's digital booklet will be sent out daily with the latest products from their exhibitors. A statement that I received from Specialized Exhibition, which is the host of Electra Mining, says, let's keep our industry connected. And I can tell you that to Gary and his team at Specialized Exhibition, we feel for you guys. This is one of the largest shows, as indicated, or the largest show of its kind in Africa. You guys make a living out of exhibitions. You are passionate about connecting people, and we are all devastated by the fact that this show cannot go ahead. But we are proud as SARS to be part of this week-long webinars that is going to be brought to you by Electra Mining. So we're looking forward to be the first to bring you this one this morning of this week webinars. Just as a matter of interest, for those that did not know that there's going to be webinars the whole week long hosted by Electra Mining Connect, you can visit their website at www.electramining.co.za and you'll see the rest of the webinars listed there. With specific to this webinar this morning, please note that the webinar is CPT verified with 2 CPT points. So our members can claim after this webinar 2 CPT points for attending this webinar. If you don't know how to do that yet as a SARS member, you can go to the professional registration page on the drop-down tab. You will find a video tutorial showing you how you can claim the 2 points. Just from a housekeeping point of view and some announcements, please note that the Q&A box, the questions and answer box, is open. But I appeal to you to not start posting questions as yet. Please wait for the presentation to be well into its time before you start posting questions, because I'm sure you might be posting a question that will be answered during the presentation in any case. There will be a panelist discussion afterwards, which will answer even more of your questions. But please feel free to make use of the Q&A to post questions specifically to this topic of this webinar this morning. You will see that the chat box is open, and I've seen a number of our members and people from all over the world has already logged in and introduced themselves and said welcome. You're welcome to use the chat box for what it's there, for chat and to say hi. You're also welcome to post any technical issues that you might experience, sound or visuals, and we have got our communications and membership manager in the background, Gareth, that will do everything in his power to make sure that everything goes smoothly and advise and assist you how to get your sound back, etc., etc. Just as a matter of interest, this webinar will be recorded. The recording links as well as the presentations will be made available to first and foremost to all our members. As per usual, we will email it directly to our members. The webinar recording and presentations will also be made available to Electra Mining Connect, and they will distribute it through their various platforms and social media platforms as well. Just if you missed any of the 13 odd webinars that SARS has already brought to you, please visit our social platforms, our website or Facebook, and you can catch up on any one of these brilliant webinars that we have conducted today so far. Right, I would like to now introduce to you the panelists. We have one main presenter, but we've got three panelists this morning that's going to join us on this webinar. And first and foremost, if I can ask Garth Hunter, please, Garth, can you share your screen with us now? Right, just by introduction, Garth Hunter is the Industrial Hygiene Specialist at Engine. He holds a Master's of Medical Science, MSc, and is registered as an occupational hygienist with SIO, as well as a registered chartered member of SIOSH. Garth also serves as a Department of Employment and Labour Government Specialist on TC7. He is a board member of the International Occupational Hygiene Association, IHOA, as well as a KZN Occupational Health COVID-19 Task Team member. Garth this morning will be doing the main presentation on a paper that he co-authored, a position paper that he co-authored with Dr. Greg Q on ventilation as a key barrier for COVID. At this stage, Dr. Q, if I can ask you to perhaps share your screen with us as well so I can introduce you. Right, Dr. Greg Q is an occupational medicine specialist registered with the Health Professional Council of South Africa. He is an associate member of the College of Public Health Medicine, the South African Society of Occupational Medicine, and honorary senior lecturer, Department of Occupational Health, Faculty of Health Sciences, UCT Medical School, as well as a member of the South African Medical Association. His education and qualifications include medical doctor, obtained University of Cape Town in 1986, awarded with honours, and the final professional examination was passed with distinction. Postgraduate training includes, postgraduate training includes grad diploma, College of Medicine SA. Greg's areas of speciality interest are occupational health management, safety and information technology, design, implementation, analysis, occupational health related law, auditing and corporate consulting, training and development of occupational health professionals, managing of workplace absenteeism, incapacity and disability, chemicals in the workplace, and in brackets, health risk management, toxicology, surveillance. Welcome to Dr. Q this morning, which is going to be part of the panelists. And the last but not the least, Sean Chester, if I can ask you to share your screen with us now. To introduce Sean, Sean will be facilitating the Q&A afterwards and try and get your questions to as many of the panelists and get as many of them to be answered. Right, Sean has a master's degree in occupational hygiene, Wits. He's a registered occupational hygienist with SIO, senior assessor with SIO Professional Certification Committee, ex-chair of the SIO PCC, honorary lecturer at the discipline of occupational and environmental health at UCT, technical director at a company called Apex Environmental, which is an Approved Inspection Authority. He's a SIOSH corporate member and also registered as a chartered member of SIOSH, member of the Durban Chamber of Commerce and Industry. In the COVID-19 pandemic response movement, Sean serves as an advisor on both the national and provincial occupational health task team. Sean has a limited curiosity for anything to do with the toxicology, microbiology, and his lifelong passion for teaching is demonstrated in the many lectures and conferences he has spoken in and committees he has served on. It gives me great pleasure now to ask maybe our two other panelists if you can stop share your camera at this stage and then hand over to Garth that's going to do the main presentation on ventilation as a key COVID barrier. Garth, over to you. If you can share your screen with us, we can see it. Thank you very much and have a great presentation. Thank you.
Thank you so much, Niels, and what a privilege it is to be able to speak to you both from a point of view of speaking to a lot of people and being able to actually hopefully make a difference at a national level. And then secondly, being able to share something which Greg and I have actually worked on. And it's so just from a personal, professional point of view, it really is a pleasure. And thank you, Niels and Sayosh, for actually making this opportunity. And of course, Electra Mining as well. And let me just go, just trying to get to move on. So this morning, what I hope to achieve is the following. We're going to cover transmission mechanisms of COVID-19. We're going to cover the types of ventilation systems and then the controls and recommendations specific to COVID-19. And also then when I speak to you, I just want to be clear that it's not just God's work. In fact, very little of it's actually my work. It's work that I've done with Greg. And we've also then taken liberally across multiple different organizations, primarily actually REVA, which is the Europeans, HA, which is Americans, as well as ASHRAE, their documents. And there's some brilliant documents out there. And also then recently, Greg and I actually listened to actually a 2-day webinar series, and we've liberally then taken out of those documents as well. So really view this as actually an aggregation of what we currently understand science to say on the subject. Instead of actually, this is certainly not God's work. It's really an aggregation. Then in terms of just an understanding to go actually into the detail is that practically actually the SARS-CoV-2 virus, which then causes COVID-19, it's 0.1 micrometers in size, micrometers in size. It dies at 56 degrees centigrade. That's important. And then it's also then, and not certainly like the early WhatsApp days when they said, no, well, when summer comes, you don't have to worry. Then it's also viable up to 9 days, and that's based on 22 studies. The early studies showed that at 72 hours it was viable on plastic and steel, and that still stands. But they also found on the Princess, where that was that cruise ship, that they found viable titers of up to 14 days. But the 22 average or mean studies, average studies showed at 9 days, and so that's what we take the viability to be. Then in terms of, and the reason why I'm covering this detail in transmissions is that it has really practical implications for ventilation. In fact, we can't really understand how to actually control if we don't understand what we're controlling. And this is a good case in point, is that the size of the droplet or the aerosol is critical. We often speak of actually the size of 0.1, and we then wear masks and we use filters, and we say that fine. Actually, we compare then the size of the filter, the size of the mask, then to the virus. But that's not correct. And the reason why that's not correct is this virus, as in all viruses, never travel alone. The virus, airborne virus, is not naked in that it travels with water, it travels with actually protein, it travels with actually salt. And this makes the size of then the droplets substantially bigger. So that's, and you see the last point of here, the physics is the same for all viruses. So it really doesn't matter how big the virus is. It's really the size of the droplet. And what we're controlling is the size of then the droplet or the particle which the virus actually then is in. It's also, you could have very high concentrations, many viruses in the single droplet. And then also importantly for ventilation is the size of the carrier droplet aerosol. It defines transport. It says how long it stays aloft. It's not based on the 0.1 micron, it's based on a much larger particle. It says how far it can travel. So we know that different, much larger particles or aerosols can actually then remain longer for far longer periods than actually smaller ones. It says how quickly it falls into surfaces. It says where it deposits in the respiratory system, and you'll see that I'll speak about that later. We also then, it speaks about then how efficiently it's removed by masks and filters. So not only, and Greg and I were actually having this discussion where not only N95, FFP2, FFP3 masks are effective, because although we measure and say that at the FFP2 masks, you measure them against actually a 0.3 micron, and you then say, well, it must control 94% It must filter out these 0.3 micron. In fact, it's the critical size of these droplets that needs to filter out is far larger. In a similar way, we often speak of and compare then the size of, we say, well, actually, we need a HEPA filter. Well, actually, if the virus is a far larger virus, practically speaking, because it's traveling in this larger droplet, it means that not only HEPA filters are actually efficient, or effective at actually removing the virus, you can actually get far, actually filters with far larger apertures that can still be effective because it's really actually controlling then the size of the droplet that this virus is actually traveling in. And then the physics is the same for all viruses. And this is another key learning. And I think that everything we share today is just based on what we understand, our current understanding to be. Just like I'm not saying that anything is actually cast in stone. A lot of the things which I've taken here, we've looked at research, and this is the best guess on what research says at the moment. If better research comes along, it'll mean that it'll actually replace what I've said. And so we're not saying anything emphatically, but we are saying that we have a far better understanding of then the disease, actually controlling it, than we actually had certainly in the early days. And one of these has been the understanding that droplets or aerosol inside the body and outside the body are different sizes. And the reason this is important for ventilation is if we're trying to actually control a particle, which is then this, because they spoke about, you see at WHO, the World Health Organization, spoke about then this less than and larger than actually then 5 microns. They said that actually then if it's less than 5 micron, it's actually an aerosol. If it's greater than 5 micron, it's actually a droplet. And inside the body, that works great, because if you inhale then these droplets or aerosol, the one is that the particles larger than 5 micron, that'd be taken out of actually circulation by your upper respiratory tract. And the ones that are smaller than 5 microns, they can find their way down to your lower respiratory tract, including your alveoli. Now, if you're then talking outside the body, and really that thing's where things actually become different, and the less than and greater than 5 micron doesn't work as a practical tool, is that the physics-based cutoff for actually then droplets aerosol is in fact around 60 to 100 micron. Is that we talk about that these large droplets are greater than 60 to 100 micron. And also then, this is really what we talk about is spray-borne or ballistic droplets. So what it means that these literally shoot out and they sprayed onto the person. And so we talk about then large droplets in terms of outside the body, they sprayed onto the body as a form of contact transmission, versus actually then particles which are less than 60 micron, they then are aerosols actually, and they are inhaled, or certainly they travel outside of the body. And so when we're talking about air conditioning, we have to then understand how the droplets and the aerosol actually behave and the size of them outside of the body. And so we're saying outside of the body, it's actually less than 60 to 100. That's your aerosol. Actually greater than 60 to 100, that's your large droplets. And it's also where these droplets actually fall. They have to find then cells which are susceptible and to becoming actually infected. And that's why we have then ACE2 receptors. Actually, we found them in the conjunctive of the eye, the nose, and actually the mouth. And that's where understanding actually, this understanding actually helps us to say that the eyes, for instance, are an important source of transmission, and that face shields from the direct ballistic drops, they add real value. And this is also then about understanding in relation to, is it at short contact or large contact? For example, if you're going to use you're in a situation where you have working within a meter, half a meter of the person, well, then actually your face shield is going to have applications, going to actually have value. If you're talking across the room, well, the face shield really doesn't, it's not protecting against the ballistic actually drops or the drops that have been sprayed on. So understanding what we're talking about and how then the droplets and the aerosol behave outside the body is important. And I think that, just to say, WHO, they created confusion by using the same numbers inside and outside the body. So this is important, you'll see, for ventilation. So we define transmission by exposure path. Then I want to cover, there was a South Korea call center, and you'll see the call center over here was a large multi-story building that there was multiple stories, and the staff at the call center, the 11th floor, worked together at desks containing 13 workstations. And this is what the call center looked like. And out of this, on the 11th floor, out of the 137 employees, 79% or 58% of them test positive. And there's some important learnings here. The one is the permanent contact time within the same space over a long period of time played a crucial role. And this introduces two concepts. The one is actually concentration, how much of the virus there is in the air. And then secondly, and that's important because that contributes towards dose. And then the other part that contributes towards dose is actually duration. So our two key factors are concentration, how much of the virus there is, and how long people are actually exposed. Together, concentration times time equals dose. And so when we talk about somebody who gets an infective dose, it means that they're exposed to high enough concentrations and they're being exposed for long enough. And then that actually relates to risk. So over here, we're talking about that people all on a single floor, that these are all the people who then became infected, and there was a high enough concentration because there's poor ventilation in the space. And then secondly, that they're all in the same space for long enough. So high enough concentration in that space, they're long enough in that space for long enough, and that's why so many people became infected. But you also then see that even if people across then the whole floor became infected, and that also speaks to then concentration. It speaks to the fact that aerosol, they became the primary transmission mechanism over here was through aerosol exposure. And that's important because our simple rules of less than or greater than actually 1.5 meter, unfortunately, there's a lot of limitations. There's some value to that in some circumstances, but there's also a lot of limitations to that simple rule. This is important. In the rest of this building, this multi-story building, only 3 people tested positive out of then the 927 who underwent checks. And they shared lobbies, elevators, and other communal areas. And why is this important for ventilation? It means that likelihood is that the virus didn't travel, although there wasn't an HVAC system, heating, ventilation, air conditioning system, with actually what we call HEPA, the high efficiency filters, the virus still didn't travel through the air conditioning system to the other floors. And that's a critical understanding. You've heard then this term, whether actually then SARS-CoV-2, COVID-19 is airborne or not. And I just want to cover that. And also then cover transmission via droplets or large droplets versus aerosols. So remember what I spoke about, and that's why it's needed to understand that background is that large droplets, we say, are greater than 60 to 100 microns. Aerosols are less than 60 to 100 microns. I'll cover then what this slide says first, or this picture shows, this graph shows first. And that is that it shows then that the exposure, this graph shows that exposure, or what is the most important exposure route, whether it's via large droplets, is actually on the above this line. It means that large droplets actually are most important contribute towards exposure. And below the line, it says that aerosols are the most important to exposure. So what we can see that if you're coughing, yes, up to 0.5 meter, that actually the large droplet, the particles or the aerosols larger than actually 60 to 100 microns are the most, contribute the most towards exposure. But look over here. most of the time it's actually then not actually, people talk. And what's the exposure through talking? And it says something interesting. It says that about 20 centimeters, 200 millimeters at, you right, literally talking face to face like this, and says even at this space over here, 20 centimeters, the contribution towards becoming infected via large droplets over 60 to 100 micron is equal to that actually via airborne exposure. Sorry, through aerosols, not airborne exposure. And why is this important? It tells us that the primary transmission mechanism of COVID-19 is through aerosols and not large droplets. Some of the organizations continue to then say, well, it's through droplet exposure. Of course, it depends what they define actually droplet exposure of as, and that can actually change things. But it's an important thing to understand that the primary mechanism of COVID-19 is through aerosol. Actually, aerosols that can travel across a room. And remember when we went back here, is that how did all these people become infected? They became infected primarily through aerosol exposure. But remember that they didn't become infected through airborne. Now, aerosol and airborne have two different meanings. What does aerosol mean? Aerosol, it means it can travel in the air. And so anything actually then less than 60 to 100 microns is an aerosol, practically. To be an airborne disease means something different. And so when you see in the media that people speak of actually then is COVID-19 an airborne disease, it means something different to aerosol. So we shouldn't speak of aerosol and airborne as the same thing. They don't mean the same thing. And even in the infectious disease community, in the CDC in the US and the World Health Organization, when they use the term airborne, they don't mean aerosol. So aerosol is anything that moves in the air. Airborne means something else, and I'm going to cover what that means. Airborne means that it has a very high attack rate or reproductivity actually rate, RO number, and it needs very little virus to actually cause infection. So to cover this, is that measles has an RO of 15. What does this mean? You need very little virus of the measles virus to actually cause an infection. COVID-19 has approximately a third of that. It means it's an RO of 5.7. For example, influenza has an RO of 1.3. Let me cover this. My boss always says that repetition brings clarity, and I think it's an important understanding, is that if you don't need much of it to cause an infection, and remember going back to this over here, is that if this was measles, the likelihood that a little virus could actually then cause infection, we would have then seen actually infections perhaps across multiple floors. And typically our understanding is that actually airborne means that it would travel across multiple floors and that you need very little of the virus to cause infection. If it's an aerosol, it means it travels through the air. Over here, we can see that multiple people, and not just people 1.5 meters away, got infected. That's because there is aerosol actually then exposure. And can be infection through aerosol exposure. So the aerosol means that it was limited to that one floor. It wasn't airborne because it didn't travel between floors. And perhaps that's the best explanation. It's worthwhile also just going through this again at a later stage for everybody listening. So COVID-19 does not spread between floors because its RO, the RO number, is not high enough. If it had a very high RO number, the likelihood is that it would actually then spread between floors. But it doesn't mean that aerosol doesn't actually then cause or it's not transmitted through aerosol. So we saw that over here, it traveled across the aerosol, the concentration of virus within that space actually built up because of poor ventilation and infected all these people. Now, aerosol means that it can actually travel. It travels far more than actually 1.5 meters. it can actually travel across the space over here. And that's how so many people actually became infected. Then another important consideration is, or just the understanding is, we've probably seen this where we get, you get somebody sneezing or coughing. Coughing can go about 2 meters, and actually sneezing can go up to 8 meters. And what happens is that the large droplets, 80 to or 60 to 100 micrometers, as well as the small, the aerosol, less than 60 to 100 micron, actually all travel in a cloud. It's not like you have this nice actually cutoff. So if somebody sneezes, everything goes and it travels moist in a moist cloud. And if this is indoors, where they found in a Japanese study that the rate of COVID-19 transmission is 18 times higher in an indoor environment than an outdoor environment. Now, why is this presentation important? I cycle, I'm a mountain biker. I went with my father, who's 90 years old. We went to actually Summerfeld, and there's a club, the Gold Circle Club, and we had breakfast there. And it was about 2 weeks ago. KZN was very cold. And there was probably around 50 people within a very small space. Because it was cold, all the windows were actually closed. They didn't have any air conditioning system at all. In fact, they had the fire going. And everybody sitting around actually then within the space. It was stuffy. And we then had to actually my father said, oh, well, he was already sitting inside. And we said, well, he said, well, let's sit inside. It's cold. I said, we'll sit outside because I understand that actually the likelihood of COVID infection within that space, because the concentration of virus is sufficiently high, and actually the duration we'd be sitting in there is sufficiently high. So we said probably took about an hour to actually have our breakfast and talk and chat and everything else. And together with a high concentration of virus and long enough time, that causes infection. And this message doesn't seem to have filtered out of South Africa at the moment. In fact, it was so cold in that morning, we sat outside one of the tables, and I kept on my cycling gloves and I kept on my helmet. And you say, well, Garth, you looked odd. I did look a bit odd. But I remember what the mayor of New York said. He said, do you choose to look funny, or do you choose death? Because if you're choosing COVID-19 infection, you're potentially choosing death. And so it becomes a much easier distinction or decision to make, to say, I'm going to actually then choose to look funny and be a bit cold. And it was quite cold. I was still quite cold outside. It was uncomfortably cold, rather than actually be inside and potentially choose death. When you've got a 90-year-old father, you literally, the likelihood of you choosing death, if there was somebody who's infected in that space, because there's a high enough concentration for long enough time period, that people could become infected. So just the transmission mechanisms are important to understand the need for ventilation. Otherwise, we'll say, well, fine, it's important. I know about ventilation, but you need to know why it's important. So there's a sufficiently high reproductive number in terms of the RO number is 5.7 for COVID-19, that if there was a person or an index case within that space, the likelihood that the concentration of virus and number of people would spread to in that building, the likelihood my father could actually catch it, and perhaps my brother and I as well, is very high. And so this also indicates then the spray-borne versus actually aerosol. So you can see over here that you have those blue droplets. If those are the droplets, the large droplets greater than 860 to 100 micron, that spray onto the person, including then the eyes. And I said then that if you get, you have ACE2 receptors, you become infected through the eyes, and that's why it's different. So controls are important at different distances. You use different controls. So having glasses, having actually face shields at short distances is very important. You then see those mid-sized droplets, and those are the green dots, and then you see the aerosol, and that can actually spread across large distances. And also important is that people say, well, actually I wear it with my mask, with my nose out, and there's a couple of problems with that. First of all, when you're breathing, there's far higher concentration of virus actually within your breath than there is if you were, let's say, singing, because it comes from the upper respiratory tract. If you're coughing also then actually through your mouth, you would have comparatively by volume actually less virus actually in that coughing than you would actually in the speaking. And the reason for that is that your breath, about half a liter actually then comes, as you breathe it out, comes from your lower respiratory tract, comes from your alveoli, your bronchioles, your bronchi, and actually you breathe that out. So speaking produces about 100 times more aerosol on a volume basis than droplets. And most of the stuff isn't really large droplets. It's actually this aerosol you're breathing out. So people who breathe through their mouth actually produce less aerosol on a volume basis than people breathing through their nose. So when you see people then breathing through, they're wearing their mask like this, if I were to wear my mask and I wear my mask like this, but my nose sticking out, I'm not being protective at all. You may as well not wear a mask at all, apart from if you're coughing or sneezing over people. It's also, this is another important slide, is that look at then the distance. What we're saying is the physics of droplet transmission, large droplet transmission. That's the spray-borne exposure. It stays in the air for around 6 seconds. The 10 micron, that's your aerosol. Think of then that Korean center, going back to here. That aerosol traveled throughout. So people breathing, talking, that's what you do in call centers. And so they're generating all this aerosol from their lower respiratory tract, from the alveoli, and that then results actually in actually transmission. So, and those 10 micron aerosol can actually remain in suspension for up to 1.5 hours. And you see that down to 0.5, it can remain in suspension for 41 hours to 21 days, virtually indefinitely. So, and this really gives a backdrop for saying why ventilation is important. If you don't remove the air and change the air out, that virus is not going down. A lot of the water will actually then evaporate off that large particle. It become then what we call a droplet nuclei. It'll remain in suspension, but it'll remain when it gets small enough, because the water's actually evaporated off. It can remain in suspension for a long time, and that's the problem with an indoor environment, is stability is not good. So we've got a couple of things. Now we're switching on to the air conditioning part. And so if we look at then, when we talk of air conditioning, you see that we speak of heating and cooling is air conditioning. Air conditioning is not ventilation. Air conditioning only speaks of heating and cooling. It doesn't speak of introducing fresh air at all. There's a Chinese restaurant example where you get a mid-wall split unit air conditioner or split unit air conditioner. It sucks the air out through a very rough, it's not even really a filter, or it's a very, very rough filter. And what it does is then you got this airflow going, and that would actually then create this circular current. And you think of then airflow patterns within a building, similarly to what you think of airflow patterns, weather patterns, because they follow very different things, very similar parts. And so what you have happening here is you have this weather pattern actually going across here. Because you don't have ventilation, you've got air conditioning, but no ventilation. You have increase in concentration. And this is patient 0 over here. That's the person who was infected. You got sufficient concentration of then that virus actually built up in that room. You had this dominant weather pattern going on over here, coming out over here, blowing here, going back here. And then you had sufficient duration. And that's why so many people became infected. Similarly, there was a Buddhist, I guess, gathering, and there was 2 buses. But then within that bus, they had all the windows closed, and they had the system, the air conditioning system, on recirculate. So what you had happening there was that you had a buildup of then concentration in that bus. You then had circulation of that aerosol. Remember what I said is that aerosol is the dominant transmission mechanism for COVID-19, and it circulates around the bus. It comes in here, gets heated up and blows out there. Maybe these guys, it was cold, and it goes around and around the bus. And you had the same thing. You had infective dose. How'd you get infective dose? Sufficient concentration for long enough duration. So these people were sitting in the bus. The infected person's breathing out, breathing out, breathing out. Remember what I said is that by breathing out, you then breathing out concentrated amounts of virus from actually your lower respiratory tract. You're talking, you're breathing out virus. That virus builds up, builds up, builds up within the space. So you get increased concentration, and they then had long enough on this bus to become infected. So 23 people got infected in the bus. On the other bus, despite the fact that people were mixing at the Buddhist ceremony, nobody else got actually infected. And so this teaches us the importance and why then in an indoor environment or confined environment is that you have really increased risk. And over here, this also speaks to the fact that you have a confined environment. The lower the volume of air within that space, again, the higher risk, because you're able to achieve higher concentrations of virus within that space. So when we speak of ventilation, when I speak of ventilation, and all the definitions, no matter which definitions you look at, it speaks of its design, supply, and removal of air to and from a treated space. When we speak of ventilation, we talk of taking fresh air from the outside and actually putting that air in and removing the air. So if we talk of air changes per hour for a building, we're talking of taking all the air. For instance, if it was an office, you take all the air out of that office, you put fresh air in, you remove the old stale air, and you do that a number of times per hour. It tells you then that that's what it speaks to, air changes per hour. And there's standards for that. So wherever we speak of, when we speak of HVAC system, HVAC stands for heating, ventilation, air conditioning. So if you have heating, you have ventilation, it means by definition, if a system doesn't introduce actually fresh air from the outside, it's not an HVAC system. It could be an air conditioning system. And this is an important difference, is we speak often of ventilation and air conditioning as if they're synonymous, the same terms. They're not. Air conditioning system only heats and actually cools the air. It doesn't bring in fresh air. And this is critical. The other point we make is that not all barriers are equal. And people, South Africans in large, for example, that restaurant scenario I'm speaking about, some people are religiously trying to wear their masks. But if you allow the concentration of virus to actually build up in that restaurant, which they did, if there was somebody infected there, it would mean that it'd be a far less effective mechanism wearing your mask, even if you're wearing the mask correctly. And I guess only about 20% of people that I've seen, I'm guessing, wear their mask correctly. And if you're not wearing your mask correctly, it really has little, if any, benefit at all. And so we shouldn't think in our workplaces as actually all barriers is equal. They're not. And social isolation, distancing from people, if you need to actually then speak to somebody and move within that space, that you can actually then get large droplet transmission, actually the medium-sized aerosol, then you move in and out of this space. Always thinking of the two principles to prevent actually then infectious dose. Dose, the concentration, reduce concentration, to reduce duration. In terms of risk reduction, when I say that not all controls are equal, if you're wearing an N95 and FFP2 respirator correctly, you've got about 90% risk reduction, which is about the same as 4.5 air changes per hour. Of course, you're able to reliably actually then provide this. This is reliant on actually people wearing it correctly. And that's actually the weakness of all PPE controls, and is you're relying on behaviors. We can see over here is that the face covering for all occupants is that we have for masks for all about a 5 to 10% reduction in the number of COVID-19 infection cases when we use masks for all. And that's with about an 85 to 90% actually compliance rate. We achieve that. It's also then when you take actually then masks and you add it to hand hygiene, you get about 10 to 20% reduction. They did a metadata analysis on studies versus actually engineering controls. Have a look at then where we move up from 1 air change per hour, you get about a 40% reduction. Remember, that's saying that you've got bringing fresh air in, up to 12 air changes per hour, where you've got 99.9% relative risk reduction. So for example, in that bus, if we had had 12 air changes per hour, we'd kept the windows open, we'd actually taken the air off recirculation, brought in outside air, we would have actually then not had the same number of infections that we did. We can understand it like this, and this speaks of then virus concentration and ventilation. Is over here, we've got then a ventilation system where we're bringing in fresh air, we're exiting the other air. And what that shows is you can then see the concentration, the number of red dots is then far lower. And that speaks to actually reducing risk. So within office buildings, people want to know, well, if I keep 1.5 distancing, if I actually put barriers or whatever, if you do that, you still actually then have aerosol, and that aerosol will travel throughout the building and you will not achieve sufficient risk reduction. So people, you could actually have a barrier over here. These people could be wearing masks or whatever, but they'd still be incredibly at risk for actually COVID-19. And we think of the Korean office building, and people actually then, the aerosol actually will distribute evenly approximately, and people throughout that floor would actually be at risk of actually then getting actually COVID-19 infections. And you can see over here that we have, there's the large droplets, there's the intermediate size one, and there's aerosol. And it's really through we said that the primary transmission mechanism is through aerosol. And so if we don't have ventilation, such as in this case, we have very, very high risk of actually transmission. What does SANS say about it? We get SANS 10, the guide to the National Building Regulation is, and then SANS 10400 Part O, 2011. You can either ventilate buildings through natural ventilation or artificial ventilation. I'm going to cover the artificial ventilation in detail here. You'll see that classrooms, we required about 2 air changes per hour. What that said is that the volume of air actually within the classroom, you had to change it out twice actually in an hour. And what did that prevent is that we've always only deemed it important. We've always said, oh, don't worry about flu. Oh, you don't be a sissy, you know, don't worry about flu at all. Despite the fact that flu killed thousands of people across nearly every country per year, we said, no, that's not so important. And what 2 air change per hour does, it allows comfort and prevents body odor. It doesn't smell stuffy. So if you go into a building, such as that restaurant I went into, and it smells stuffy, you're not even achieving the 2 air changes per hour. If we look at then what SANS then said for trauma ER waiting rooms, radiology waiting rooms, and triage, what did they say that you needed? They said you needed 12 air changes per hour. In this time of COVID, then you'll see that really what they're saying is that's what we need. And all the science actually and the numbers actually agree with that number approximately. It depends really actually more air change per hour is more of a thumb suck in terms of it's a rule of thumb, where if you have a larger building, a larger volume, the number of air changes per hour actually then varies. And you need to work off the liters per second per person. ASHRAE was then it's American organization, and we've always worked off 700 ppm, keeping CO2 concentrations less than 700 parts per million above ambient. So in terms of CO2, is that people breathe out CO2, and CO2, all of us do at a fairly constant rate. And CO2 is an excellent guidance, an excellent marker of actually indoor air quality. And research done actually shows that ASHRAE guidance of keeping actually CO2 less than 700 above ambient, the outside air, you're saying you take the ambient air, if the ambient air was at 400 ppm, you add 700 to 1100, you say you must keep it below that. And so it depends. You get quite a variation in ambient CO2. I've seen readings from around 380 ppm to around 520 is high. How's that? And that's why we baseline it against that, because we're interested in the CO2 being breathed out by people. And so to be more accurate, we work off then the ppm above ambient. We take ambient, we add it the 700 to above it, and we must keep that CO2 concentrations below that. But what research shows that keeping to that standard, the old standard, which we've worked off for years, it doesn't prevent measles, doesn't prevent influenza, which is then quite a low RO value, or rhinovirus in an office or school. And what's fairly evident is that one of the dominant transmission mechanisms of us all becoming sick, actually then it isn't just the person sitting next to you, but if the primary transmission mechanism is through aerosol, it means that if I was in a room and I was actually had influenza and you're sitting in there the whole day and I'm even 6-8 meters away, that because of the buildup of concentration, the duration that it'd be in that room, you'd actually be at risk of then catching that influenza. And we've come to accept this as a normal. Of course, one of the advantages of actually then COVID-19 is making us rethink that. So what should we be aiming for? We should be aiming for to keep CO2 above outdoor air of less than 400. So we reduce it from 700 to 400. And that equates to fresh air, face air liters per second per person of 15 liters per second per person. That's what we need to be delivering, is 15 liters per second per person of fresh outside air for every person that's in the room. So if I had 10 people in the room, I'd need to then times that the 15 by actually 10 and deliver 150 liters for the people actually in that room. And that approximately equates to 12 air changes per hour. For lay people, and I'm sure that people unfamiliar, because I know I took a while to understand this ppm above ambient, what it equates to is that if you say ppm, CO2 is running at about 400 ppm, and then we take then the 400, that 400 value over here, and we add those together, we get 800 ppm. It's also, we need actually then, if we're going to measure CO2, we need to actually have a practical value to benchmark against. And because you can't set it at, unless it's a very complex CO2 meter, where you have one indoors and outdoors, it becomes too complex. So what am I saying? That if we have a continuous CO2 data logger, and we put this on the wall, and we set it to alarm at a certain point, is that we should set it to alarm at 800 ppm. That's sufficiently protective. The CO2 concentrations are very rarely below 400 ppm. I've seen lower than that, but not much lower than that. And often they're higher than that, certainly within urban environments. So it's a fairly safe actually standard guidance value, not standard guidance value, to set your CO2 meter, put it on the wall, and saying if your CO2 goes above 800 parts per million, what that means that's indicative of the fact that you're not meeting 15 liters per second per person, and you're not having approximately 12 air changes per hour. You'll see the graph below there, and the darker blue line. And you also then, what we also see from this graph is the duration, is that CO2 is a marker of non-compliance. It isn't the marker of compliance. Why do I say that? If you've just walked into, people have just occupied a room, they've been there 15 minutes, you go and measure CO2, you're going to be compliant. Even if the room has no ventilation, you'll be compliant. And it's also that if you have one person in that room, you go and measure CO2, you say, oh, now the room's compliant. If you actually take the room to full occupancy and they're there for longer than 2 hours, you can see this graph over here, that the people would then need to be there approximately for 2 hours. Then that would show then whether the room was actually, then you had adequate ventilation to that room. So what we're saying is, just summarize, repetition brings clarity, is that practically speaking, we need to actually then have CO2 data loggers in order to determine compliance. Real time, particularly when you actually have lots of people in the room. You put a CO2 data logger, you set it at 800 ppm. If the CO2 meter actually alarms showing that the CO2 concentration in that room is greater than 800 ppm, it means that you are not emitting levels, or you've got levels of actually then CO2, you've got levels that if somebody were infected within that room, that the other people in that room would be at risk of becoming infected by that HPA, including actually COVID-19. So we're saying that if we keep the concentrations of CO2 to less than 800 ppm, that we're introducing a significant risk reduction. We've got approximately 12 air changes per hour, and we've got delivering at approximately 15 liters per second per person of fresh outdoor air. What about natural ventilation? We've got different types of natural ventilation. You'll see over here that we've got local single-sided ventilation, and that's always difficult. You know that when does somebody say, close the door? It's always when you've got a window on the other side of the building. If you've got only ventilation and windows that open on one side of a building, you can have limited ventilation, but it's highly unlikely that you also then can actually meet the requirement of delivering 15 liters per second per person. The most effective, typically, natural ventilation is when you actually have cross ventilation. So local cross ventilation, you have windows open on this side of the building, windows open on that side of the building, and you have cross ventilation. But depending on which direction the wind is blowing from and how fast the wind is blowing, it might be very still conditions. So even if you open up all the windows, you're still not able to achieve actually good ventilation or sufficient ventilation. It's also then that the basic minimum, which is actually you have to have 5%, the windows in a building have to be at least 5% of the total floor area of the building. That's not going to be sufficient for COVID, because that was approximately set up to deliver 2 air changes per hour. It's also then, so what am I saying about local ventilation? I am saying that it's very difficult to control actually COVID through natural ventilation. So, and that's where you can actually measure CO2, and without actually measurement of CO2, it's very difficult to establish what's happening in that building. You can also get buoyancy driven stack ventilation, your twirly whirlies on the top of a building and suck the air out. The air comes in through this direction over here. They can also be effective. Then we also then have probably the most common air conditioning system, not ventilation, air conditioning system, heating and cooling system, which is then no ventilation at all. And that's what we feel comfortable, because it's nice and cool. It feels like the air quality here is good. But after a while, we start getting tired actually within the building. And we all know it. And that's because the CO2 concentration is building up. And I've seen CO2 concentrations, I'm an occupational hygienist, CO2 concentrations around 2,500 parts per million. And even in terms of decrements and thinking, is that it makes sense from a productivity point of view to actually keep your CO2 actually to below at least 700 parts per million above ambient. So we can get, there's just so many downsides to having this type of ventilation system. What we're saying is your mid-wall split unit system, it doesn't have any fresh air capability. Your split unit system, it is not a ventilation system. It just recirculates and actually cools or heats the air. So when so the only ventilation you can have with this system is through opening windows or doors. And I spoke to somebody today and they said, well, actually, because it's a computer room, they're actually now they've welded the windows shut, and so no ventilation is possible at all. And this is really probably the single biggest risk in terms of air conditioning system with no ventilation across South Africa, is this type of system here. Is that the risk becomes sky high. Most people have no idea what the CO2 concentration in the building is. They also don't know that there's actually not ventilation in that system. That restaurant which I spoke about, that's a type of ventilation, or it's a type of air conditioning system they have, because there isn't ventilation. And you can see over here, there's a heating cooling unit. It supplies air ducts, whatever supplies the room, but there's no exhaust or supply ventilation. Then we can also then have I've seen them, actually at NGen, I work for NGen, we've got them, but we have relatively few of them. And that you have a split unit air conditioning system with a mechanical ventilation system. So what that looks like is that you have then a cooling system, but you then, so this would be your cooling, or your cooling system, and then you have a ventilation system. And you can either have an exhaust ventilation system, which means you suck the air out and actually fresh air would come in through air vents and other places, or you can supply. You can have a supply ventilation system, and that's where you push air into the room and the other air or stale air is actually pushed out. This can be a very valid form of ventilation, but it means that you can actually supplement. You don't have to do away with your split unit air conditioning. You put an additional separate ventilation system which either sucks air out of a building, exhausts it out, or supplies air into the building. And this is probably, these systems don't necessarily need to be that expensive. At our plant in Cape Town, our office in Cape Town, our terminal, we looked at it, and for the whole building, it's quite a big building. It was going to cost around 80,000 to add a mechanical ventilation system to supplement, or not to supplement, to supply ventilation, because currently we only then had actually then a heating and cooling system. This shows then really the power of ventilation, is that this was actually then an Iranian hospital, and all these people, this was in a COVID-19 positive ward, and all these people over here were COVID-19 positive. And what they did was they air sampled actually then within this building. They sampled this, and they found that they didn't pick up the SARS-CoV-2 virus, even though from 2 meters from these people's beds, even though all these people were actually COVID-19 positive. Contrast that with and that's because the aerosol was being sucked out the room. They didn't allow the concentration of virus to build up in the room. That was at 36 liters per second per person. It also speaks to, depending on the risk of that particular building, you may need, certainly in healthcare settings, you need higher ventilation rates than 12 air changes per hour or 15 liters per second per person. But it speaks to it that compare that with then the Korean center, call center, where you had a huge room, but you had build-up concentration of virus within that room. Then this is your HVAC system. So HVAC stands for heating, ventilation, air conditioning system. And you have then a central air handling unit. And that is, for instance, we have in our Cape Town, we have an 8-story building, and that's where you have your traditional, what we call air conditioning system. It's a full air conditioning and ventilation system. That's why it's heating, ventilation, air conditioning. So it provides heating, it provides ventilation, provides outside air, and it heats and cools. So over here, that's we also then have a recirculation damper. And what we're saying is that we should be exhausting all the air. That's the recommendation from REVA, from ASHRAE, from AIHA, all the organizations saying that we should be setting the recirculation damper to take 100% outdoor air. I'm not going to go through in detail through these interventions, but I'd suggest that you look at then, this is from REVA, increase airflow, force dampers to introduce outdoor air only, and there you go. And it says then the types of controls that are needed. Go and look in detail at the REVA document. It's excellent. Now we have assessment of all buildings. What does this look practically like in terms of taking the information that you've gained here and translating that into practice? And I work for NGen, I'm the group hygienist, and this is what we've done, is that this was done at one of our plants, a big plant, where these buildings over here, it was a central training facility, and we have a HVAC system. Yes, we have ventilation there. And so what we looked at is we looked at and assessed each building has to be assessed separately. Often what I've seen is people then say, well, how long can I occupy this building for and how many people can be there? And they want a one size fits all. I'll say this emphatically now, there isn't a one size fits all. You really have to assess each building, even the ventilation system. you have to assess that ventilation system independently. And we looked at whether we've got natural ventilation, whether there's windows, doors, cooling system, mechanical ventilation, whether dampers were open, whether it was compliant with SANS 10004 Part O, whether it's outdoor air, the floor area, and the number of people that the building could accommodate for social distancing. This is now an important concept, is the limitations of use. So in order to be able to use that building through the COVID-19 pandemic, it can take 23 people. We worked that out based on the floor area and the spacing. Plus we had to monitor for CO2. So we bought then real-time CO2 monitors, and we've assessed then that we've actually keeping at the CO2 concentration less than 400 above ambient, less than 800 ppm, because that we set them to alarm at. And we have assessed all these buildings. Then in terms of, let's take where we've got a split unit air conditioning system, we don't have a mechanical ventilation system. And so it means that we don't have ventilation to that area, to that building. And what we've assessed it is that this building can then take seven people. You have to keep the windows or doors open for the duration. And what that means is that you actually have to have a sticker on each of the building and saying, keep open while in use. Plus you have to then measure CO2 concentration. So you can see the limitations or the conditions of use actually then differ whether you've got an HVAC system or split unit air conditioning system. For the HVAC system, we didn't need to keep the windows and the doors open because we had ventilation. Where we had a split unit system for the other building, we have to actually keep the doors open. And so you develop limitations of use, which says when you use this building, this is what you have to do. But basically, throughout the workplace, you build an Excel spreadsheet. You say, this is what we need to look at, and you decide what the limitations of use are. And actually then everybody understands, maybe it's on the door of the building and says, this is the limitations for use. This is what you should be doing. You'll then see for healthcare facilities that you have more requirements, and that's where you talk about HEPA filters. Then cover another aspect of ventilation is that what's the difference between a HEPA filter? HEPA filter captures 99.97% of particles with the size of 0.3 microns. Now, if we ask ourselves, do we need HEPA filters? Remember what we said, the transmission mechanism and how we relate that to this is the virus doesn't travel alone. It's the size of the larger particle, the size of the larger aerosol or droplet, large droplet. That's actually important, and not the size of actually the virus, because that virus comes even once it's dried up. It has salts, it has protein, and so it's still far larger than actually a plain virus. So is this size of 0.3 microns critical? Within the healthcare environment, absolutely. But within a non-healthcare environment, is that there's also what we call MERV filters, which is the minimum efficiency reporting value filters. And they have a scale of 1 to 20. And with MERV filters, it captures 95% of particles in the entire size range from 0.3 microns through to 10 microns. The suggestion is that if you need to filter in the non-healthcare setting, that these may be more appropriate. You need to then consider this in terms of understanding actually then what pollutants you have, what risk of the building you have. For instance, if this was in a healthcare setting, even actually an occupational health clinic, you need perhaps actually, I'd suggest that actually having HEPA filters, if you're going to need filters there, are more reasonably practicable in that setting than in a far lower risk setting. It also then, you've got to actually ask yourself, well, if we actually exiting all the old air, we've got the dampers fully open, if you've got an HVAC system, then why are you actually filtering the building, filtering actually the air? Because you've got actually, you're not actually taking any air through the filter. It's also then, and one of the REVA recommendations is to use MERV filter ratings in the 13 to 15 range. And that may be appropriate. I'm saying it's probably likely to be appropriate. You need to then check then with a ventilation technician or ventilation engineer in order to in more detail assess the system. But what I am highlighting to you here is that HEPA, it's not no filters or standard filters, and actually HEPA filters, it's not binary like that. There's more options than that. Of course, changing filters is not simple. You get increased pressure load because on the system, and the system may not be designed for that. You can also get air bypassing the filters. You'd have increased maintenance. You have to have increased filter changes. And so changing the filters should not be done without understanding the implications of that. The conclusion is understanding the role of ventilation in reducing influenza infections is not new. This is from 2011. They found in the US, and this is 2011 figures, is increasing the ventilation rate from about 8 liters per second per person to 15 liters per second per person would save the US economy by about $37.5 billion per year through reduced absenteeism and employee performance. Yes, you get increased employee performance, including through actually then the decrements and actually then processing capability. When we get high CO2 concentrations, our performance goes down. And compared to then this relatively small cost of increased actually energy costs, we get massive savings. And I think it's perhaps taken actually COVID-19 to actually show us this. But of course, the question is, are we going to learn our lesson, or are we just going to revert to what we knew before COVID? So I'm suggesting this is not just a talk about COVID-19, and that you can go back to what you did beforehand, that the world pre and post COVID-19 is fundamentally different, including a permanent priority change in the role control of HBA. We're not only concerned with actually then controlling body odor. I mean, we're living in the 21st century, 2020, and all we're concerned about is actually controlling body odor. We're not concerned about the deaths and actually the morbidity attached to actually influenza. Well, if we're concerned about running good businesses, I suggest that we should be. And so what I'm suggesting is that a permanent change. And the recommendation then is to achieve ventilation rates of 15 liters per second per person. And that'll stand even once the COVID-19 pandemic has passed. The last slide is that you also need to consider where you are. So what do I mean by that? If you in inner city, Durban, Joburg, Cape Town, that you also then have morbidity and mortality of impacts through outdoor air pollution. And if you get diesel introduce even particles down to nanoparticles, PM 2.5, that's PM 2.5 micrometers, and those reach the lower respiratory tract. So the morbidity and mortality impacts of then outdoor pollution is well understood. And whether you choose to then, even post-COVID, to actually then, and within pre-COVID at the moment and post-COVID, whether you decide to either filter the air or exit the air, change over the air, will depend on where you are. And so no one size fits all. And this is where you need to actually then discuss and understand where you are, what are your options, whether you should be using MERV filters, what level MERV filters you should be using. But what it showed was this, is that by putting MERV filters in, you can see Delhi's the topmost one, by using MERV filters in the range of 13 to 15, that they saved about $750 per person per year. And you can see over here in London is that the saving is about $170 per person per year. And you saw the huge mortality and morbidity impacts by actually using MERV filters. So what I'm saying is that, just in conclusion, is that consider this: higher atmospheric pollution outside, you should be relying more on filters. Of course, CO2 becomes less useful. And then if you've got lower atmospheric pollution outside, you should be more relying on outdoor air. So also use always the least complex solution. We had the question whether you should be using then a HEPA filter within then a building, but that's adopting a more complex solution for actually a far simpler problem. So we should always use the least complex solution. And so if you're in an area where the air is relatively clean outside, change over the air, get the outdoor air in. get the indoor air out. If you're in a polluted environment, consider then you'll need to actually consider then higher level MERV filters or even HEPA filters, depending on your risk. So with that, thank you. And we can open up for questions. Thanks.
Cool. Thank you very much for a very, very interesting and comprehensive presentation. Might be for some, including myself, a bit technical at stages, but I can tell you what the messages came across clear as daylight. And we're going to jump straight into the Q&A session, which I see Sean has already put his camera on. He's looked at some of the questions. It looks like there's about 10 or 11 great questions that we're going to pose to the panelists. Dr. Q, if I can ask you possibly to put your camera on as well as have your mic on standby. Sean, over to you. Thank you very much. Let's get to the Q&A because lots of people are waiting for that. Thanks.
Niels, thank you very much, and Gareth for the technical side. Garth, brilliant presentation. Very well done. Flipping high technical stuff this, and I don't know if people actually understand the true involvement that it actually takes to be able to present something like this. So very well done for your presentation, and both
thanks to Greg as well.
Yes, and to Greg, I was going to say, it's Greg and Garth, this I understand, and I know from dealing with this for a few weeks now, this position paper, this has taken hundreds and hundreds of hours of collating. So the people that are sitting here still and are still into the Q&A session, really being given this opportunity to actually have this information brought to our doorstep. This is a lot of work that's just been presented in just over an hour. So thank you so much to both of you for taking the time and having the passion to actually sift through this stuff. That's really fantastic. Thank you very much. Greg, we're going to jump in straight into a little bit of a transmission thing. There's been a lot of questions around transmission, and if you, let's just say, for example, you've got this wonderful building. Let's use the South Korean example, or even the bus. And if you had 20 air changes per hour, say, ideally in an ideal world, would the transmission have been a bit lower relative to what it's already what it was actually recorded as, and why? And I'm considering also looking at the proximity of people to each other, and looking at the way that dilution works, and that the pathway that aerosols actually have to travel to be able to get filtered out and diluted by the ventilation system. I hope I've posed that question well. Thank you.
Thank you, Sean. Yes, certainly the ventilation is the engineering solution. It's the barrier that one needs to set in place as a foundation for everything else. There's no doubt about that. The importance of that as a barrier is that it doesn't depend on behavioral compliances. But one also needs to consider that ventilation is primarily a dilution control. So for people sitting close to one another, and for people who are breathing heavily, say for example, not that particular environment in an office environment, but let's say you're in a factory or a shutdown or somewhere where people are breathing heavily, and you have people close to each other. Under those circumstances, you're going to need additional layers of control. But even in an office environment, people sitting close to each other, the aerosol scientists, this is a science that Garth and I have recently discovered, they talk of the plume range, P-L-U-M-E, plume range, and room range. So plume range means you're breathing closely enough to the person near you to breathe on that person. And in plume range, ventilation is less effective. At room range, for the rest of the room, ventilation is incredibly effective. So perhaps just in summary, then the point that you're making is that if you're sitting closely enough to be in someone's plume, breathing plume, then that's where masks and other controls are very necessary. And so they bring us to the last point, bring us to the conclusion that multiple layers of controls are really where your ultimate success lies. Thank you.
Great, thank you very much. Just on a personal note, just in a very brief answer, if you don't mind, just humoring me, the use of valves in masks. Do you have any questions or comments around that?
Yes, indeed. A single answer: they should be banned. How about that as a quick answer? They really make no sense at all. All you're doing is you're just breathing out in your outward breath plume. You're breathing out viruses unchecked. And in fact, you might even be creating a small jet out of that little narrowed aperture, which is making it even worse. So they should be banned. They look sexy, but not a good idea.
Thank you. And Garth, this might be for you. What happens when an employer continues to locate employees in a closed environment, working close together, just with air conditioning and no natural ventilation or supply? What are the rights of the employees in this environment?
Well, first of all, it's not good business. So even if you don't care about the employees, just not clever from a business perspective. Because I mean, you shut down your business. It's also people don't feel cared for. If you don't feel cared for, people you don't feel cared for, you don't build a meaningful business. So that's just by the by. Of course, what your rights are is that yeah, you have the right to actually refuse to work in terms of the OSH Act. But we know that's difficult, and we know then that it's often things are actually stacked against then the employees being able to actually do that. So I mean, you'd heard actually then the culture presentation I gave. Always the best thing to do is to actually then start with understanding. Try not to actually build up a confrontative situation, and it's only then when everything else fails really go to we downing tools. But certainly it's important to get the change quickly and get it in a time frame which is not going to bring unacceptable risk. So it's not an easy question, but first of all, try to deal with it in a amicable, in a way that brings understanding, and including actually sharing this, asking, well, can you watch this? And also Tibuswana, our chief inspector, always speaks of then the role of the health and safety committee and representatives. And yes, they should have a bigger role. He's entirely right in that. And so involve your actually representatives, involve your union representatives. This is incredibly important and something really that union people really should be pushing, because it's not right ethically or not good business. There's just no good reasons why we should accept poor ventilation. And remember what the mayor of New York said: choose this discomfort, even if it's cold, or choose death, because that's what COVID has brought about. It's a very clear decision to make.
Yeah, thanks, Garth. And I know I put you on the spot over there, but I think it was an important question to be answered. And yeah, I mean, and I suppose Greg can come in on this as well, because when you start looking at just good business, Garth, the emphasis on your part, and I think that's a big takeaway for this. And just the reduction overall in absenteeism, the increase in productivity, and that sort of stuff, that these ancillary sort of knock-on effects that have been sort of the positives out of the COVID scene. And I suppose, Greg, you could maybe answer on even on the absenteeism side of things in general. Has there been a good amount of reduction?
Yes, indeed. Garth gave some very useful insights into the differences between flu, perhaps, and COVID in terms of their reproductive rates or their attack rates. The COVID attack rate is higher than that of flu. So all our efforts to reduce COVID have definitely reduced flu. So there's been a massive reduction in the flu rates around the country. So some of the learnings, perhaps, from this encounter is to take our ventilation and controls more seriously. We've just lived with flu all these years. God made that point. The other thing that perhaps is an important control, combined with all of the things that we mentioned today, is identify the person who has flu and get him out of the office. Or preferably don't come to the office if you've got flu. So to remove the source, to dilute the breath that the source happens to be breathing, if the source happens to be there, and contain it at source where possible.
Well, I don't know about the rest of the audience, but that was a goosebump moment for me. Thank you. It was a really good piece of realization. I really do appreciate that. And I think, when we start talking about the difficulties of individual buildings, there's quite a few people asking, what happens in my environment where I have no air conditioning, or if there's load shedding and the ventilation goes down, and therefore there's no access to open and natural ventilation systems. And I think the answer would be, and you can please come in if you feel like you need to, would be do the risk assessment and then adopt the policies and the protocols that are actually around that risk assessment, and consult widely, etc. So very good.
Totally agree.
This one is, it's just, I'm going to do it directly because it's this: high importance of ventilation surveys by an approved inspection authority for workplaces now in time of COVID-19. In the past, and in my experience, ventilation surveys focus primarily on CO2 and not necessarily the spread of hazardous biological agents. Yeah, I think I just want to just Garth, before you even open the discussion there, just remember that an approving inspection authority is one thing, but an occupational hygienist I think is more important and critical to the point that this person's trying to make. I think ask if that's okay.
Uh, the need to it's the need to assess. Of course, it depends again on what you're wanting to assess and what standards you're wanting to assess against. So I'd take this back to what do you want to do with your HSEQ system in terms of, I know Greg and I have asked this, do you just want to meet legal compliance, or do you want to actually then protect the health and safety of your employees? And I think that's an important consideration. So even the same, because the employer often informs the AIA what to do. So in terms of then the standards of which, if you want actually the AIA to just use the body odor and that's all you want to control is body odor, then that's what you can do. These regulations are actually, I think, end the Department of Employment and Labor regulations end the end of October, is it? But they're not going to be enforced forever. And so that's my point, is that the employer needs to decide, what do you want to control? Are you actually interested in protecting health and safety, or do you want to just meet legal compliance? So yes, the Approved Inspection Authority can play an incredibly important role and useful role, but allow them to, give them the space to. For instance, at NGen, if we feel that actually a value is of not of much value, or it doesn't bring the risk mitigation that we need to, what we do is we look for another standard, and then we tell the AIA, we say, well, this is what we want to achieve. So I think then that what I'm saying is give the AIA the liberty to actually then to do what they need, and also then expect of the AIA. So for instance, if there's a building and the building's not occupied and you go and measure CO2 there, what does that value mean? I'll tell you, it doesn't mean much. So there has to be a far higher interrogation and understanding what first of all, saying what you want to achieve out of it before you start doing it. And second of all, what you do with the results when you get back. You have to know what you have to do with it. And you also have to take it through a corrective action process. So all the systems are needed in order to, it's not just about the measurement. It's understanding why you're doing the measurement, using the measurement, making a change with the measurement. And the rest are really technical details at the end of the day.
Thank you, Garth. Yeah, I think it generally goes to ask the question, what is the question, and then answer it. And make sure you answer it with competence. You know, consult people that are in the field that are competent. A lot of Harold posed the question that was pretty similar, and that's about suppliers and manufacturers of ventilation systems. Are they deemed competent to take their own system? So it might be, you might have to have a sort of a two-barrel approach where you've got competence as well as independence, and that verification has to be both competent and independent. So you can pose the question, then get somebody that's actually experienced enough to be able to answer that question in there to answer it. So it goes back into like also whether it's monitoring systems, or you mentioned about carbon dioxide meters. You can have one and you can actually walk around with a handheld device, and then you might measure an environment and say that it's actually CO2 clear, let's just say under 800 or whatever it is ppm, but then you didn't look at it at full occupancy. So it might be better for your risk assessment, or your question might be to have a permanent fixed system inside there to actually measure that. And actually that can be relayed into a control room, and you can actually get those sorts of checks as well. So yeah, thank you very much for that. And this is a, sorry, Greg.
Can I make just a quick comment to add? I think one of the discoveries in this journey that Garth and I took that is perhaps really worth sharing with the rest of the folks listening in, is that up until now, I certainly as a medical practitioner didn't have a number attached to what would be a good ventilation rate for a room for a biological agent such as flu or coronavirus. And what Garth has shared today, I thought is incredibly helpful. And the point is that there's alignment between the value of CO2 of 400 above ambient with studies that show that at that level, 400 below ambient, above ambient, is sufficient to reduce the risk of viral transmission And that link with the clean air requirements of the European standard, I found stunningly attractive. There was direct correlation that says the same level for good clean air in terms of CEN happens to be the same level for good viral reduction from scientific studies done. So it gives us something to work with. For the first time myself, I can go to my clients now and say, if you've got split air cons and you're not quite sure what the ventilation rates are and you want to open the windows, you're still not sure, you can do a CO2 level. If it's 400 above ambient and no more, you're generally doing okay. Thanks.
Yeah, just to add on what Greg said there, it's incredibly important what he said, is that we looked at multiple different sources in terms of, we looked at actually then the liters per second, we looked at the air change per hour, we looked at the CO2, we looked at actually research actually in terms of we looked at the research behind actually then the CO2 values in terms of and people who did assess then what CO2 would actually prevent these viral transmissions and transmissions of HPA. And guess what? It all added up. It's not often that you get the situation where the numbers actually all align so nicely. And what I was trying to also show is then that even actually then if you look at the SANS 10400 part O, that also lines up when you look at then when you're trying to prevent actually transmission 12 air change per hour. So yes.
All right, thank you very much for that, guys. I see Niels is coming in to try and maybe end the Q&A session. Could I just post one more?
Not to end. No, please go ahead. I'm looking at percentage-wise. I think we're still on about 90% of our original attendees are still there. I would just like us maybe to get, there's some interesting ones lining up, some plain questions that if we can maybe speed up to try and get as many as possible. Thanks, Sean.
Well, yeah, talking about plane questions, we can't go any further without knocking that one out the park. Aeroplanes, how safe are they?
Well, actually, I looked at this in detail. Aeroplanes, the older planes, some of them didn't have HEPA filters, but they've all the modern planes have got HEPA filters. And so it goes around what I said is that you can either filter out the air or change the air. They've got a fair amount of air changes per hour, actually, the airplanes. And what they found was that because you reducing then the concentration of virus, the immediate, that's where you reduce the, what Greg said earlier on is that it's the immediate droplets and you reduce the plume, and so your overall concentration is low. So really the risk is limited to the people in actually the immediate row next to you, actually in front of you, or actually behind you. And then also, by the way, they found that they definitively found that the lowest risk seat on the plane was actually the window seat. Sorry, the window seat. Yeah.
Okay. Thanks for that, guys. Greg, I got quite a good question over here, and I think it sounds simple at the outset, but I think it is a little bit more complex. So Dr. Grady said, if you find someone with flu in your office, remove him. Is flu and COVID-19 the same? And are we getting this even in our own organization? The doctors are saying just a common cold or flu on the sick note, you know? So yeah, let's hear what you have to say about that.
Thank you for that kind question. There's still much being discovered about COVID, of course, but what I can say is it's a coronavirus. Coronaviruses are not new. They have been with us for many decades. The seasonal flu and the seasonal upper respiratory tract infection burden that humankind has been faced with for many, many decades but is partly contributed to by coronaviruses. So perhaps somewhere in there lies a message that this is a new virus. It has a different phylogenetic sort of makeup, and of course it is more. It has a higher attack rate and it has a higher case fatality rate. So it's not the same virus, but there are many similarities, and we can, in terms of our controls and our preventive measures, they're pretty much the same. So whatever we're doing for a flu person, at least for COVID, we do for flu. And what perhaps last sentence is, where we started out at the beginning of the pandemic saying, if you have these symptoms, you're likely to be COVID. If you have these symptoms, you're likely to be flu. Well, it took us a couple of months to realize that defining difference is really an entirely artificial one. The symptoms overlap so much. that it's really almost impossible without doing a swab test to just distinguish between one from the other, clinically speaking.
Thank you very much for that, Greg. Air changes power. It's been the question. One or two people have asked about that. Is the air changes power that's been described in all these calculations and everything like that is fresh air? I just want to confirm it is fresh air and it's not the recycled air, obviously.
Correct.
Yeah.
Yes.
So this one over here, question. When miners go underground and there are 50 workers in a cage going underground, will the cage be giving adequate air ventilation when the cage moves down? I think we've kind of answered that. I mean, the fact when you look at proximity, there's obviously enough dilution rates inside mines. The mines are got very force-fed, high amounts of ventilation. However, when you are sitting within that proximity that Garth spoke about, and then you'd obviously have to start putting other barriers up, like masks, all the way through.
Yeah, distance and your controls and understanding controls and distance, and there's really becomes the important thing, not the overall dilution rates. So dilution is not going to help you there. You've already got adequate dilution.
So talking about controlling aerosols by other mechanisms other than ventilation, what about fogging systems, UV lights, or anything like that? Is there any insight from the two of you about those?
Non-healthcare is that so if you in healthcare actually UVC I think it's 222 bandwidth then has value and be quite effective on actually fomites, and also then actually controlling actually in air it needs to be quite a stable environment. That goes to my earlier point is don't choose the most complex solution. So if you really forced to go that, but it's not your first option. Your first option is dilute, ventilate. Then if you can't control through those methods, then yes, certainly look to other methods, and also then control for risk. Greg?
Yeah, I think great answer, Garth. Perhaps just a couple of sentences about UV. There's UVA, UVB, UVC, and even UVC isn't all the same. There's what they call near and far. Garth made the point at about 222 nanometers. That's the spot to aim for. It's called far UVC. UVA and B, carcinogenic, not so good, and cause burns. UVC is much less hazardous to humans. And at 222, that's the sweet spot. Garth also makes the point it's more complex than just dilution, ventilation, opening windows, but it has certainly been shown to be effective. Also, Garth makes the point you need to have a minimum contact time for that UVC to be effective. So minimum contact time means that you can't put it into a ducting, and as the air brushes past, think that the UVC is going to clear that air. You need a good 8 seconds of contact time before any impact is going to be made by that UVC.
Actually, Greg and I looked at this one. We had many discussions over it, and so what we often do is we got a ridiculous amount of detail, and so this was one of those, and that's why we're so well prepared for that question. Sean must have fed the question, I think.
I think it was brilliantly answered, and I certainly have a better understanding for it now about it now. Thank you. This one, I think it's, and this you can actually relate this to other workplaces as well, where you've got this person's got a manganese plant, very high contents of manganese dust and ammonia fumes within the environment outside. They've got air conditioners in the eating rooms and offices, but cannot open windows and doors due to for cross ventilation due to the dust and fumes that are outside. What do you suggest we install?
MERV filters. That's what in the range of 13 to 15. Absolutely. What do you think, Sean?
Absolutely. I mean, we've got to filter out whether we're scavenging them, especially if there's gases. You can actually find other ways of actually scavenging the air as well. So there are options out there. They are very expensive, but they are certainly reasonably practicable in the context of absenteeism, higher productivity, COVID, and death prevention. I suppose we look at it like that. Harold wanted us to explain the calculation for air changes per hour. Only he would ask a question like that. I don't think we need to go into the detail of it. I think the idea or the ideal answer would be we should get into our ventilation engineers when we're working with these things. But if you have a simple answer for the audience, would you be, could you present that?
Go to Google, type it in, and it'll give you the calculation. Actually, that's commonly available. It's readily available. So I mean, actually, in our technical document, Greg and I also provided, and this is layers, is that we provided actually then a basic technical document, but now a more detailed technical document, we actually give that number and that calculation for air changes per hour. It's all standard vent. Thanks.
All right, guys. I think I see Neil says now, but I'd like to just maybe ask one more question for the good doctor, and it's more of a medical question directly. What about pregnant women in the COVID pandemic? Is there anything that you could suggest or have insight into with that?
Right. Why does he save the tricky question to the end? Niels, I'm sure we've run out of time.
Not for that question, Dr. Q, not for that one.
The good news generally is that this has been looked at quite extensively, and whilst pregnancy may be a risk to the pregnant person, and there's a story behind that, the risk to the baby and the infant is relatively low. So the current understanding is that when it comes to pregnancy risk, you don't want to expose any baby, especially during the first trimester and the second trimester, to any biological agent. You don't want to anyway, for various reasons, because of the illness itself can impact the developing baby just from the elevated temperature. But fortunately, COVID seems to be a relatively low hazard to the developing baby. So that's the general good news. But bear in mind that the mom might be at risk, and there are technical reasons why in the first trimester, second trimester, and certainly the last trimester before birth, where the mom herself might be at risk from COVID. If you have COVID as a pregnant person, the mom, through the cardiovascular system, respiratory system, and the kidneys, are at increased risk.
Well, thank you for that. What can I say? Thank you for the questions, and really thank you for the audience. We still had 313, so there's been a hell of a involvement in the Q&A session as well, and I'm sure we could go on for ages. So thank you both for your very intelligent and comprehensive and insightful and well-researched answers. Thank you so much. Appreciate that. Niels, over to you.
Thank you, guys. Just remain on with your cameras, please, just for the quick closing and the final thank you for your participation. Just in closing then, just a reminder to our members that this webinar was CPD verified by SARS with 2 CPD points, so don't forget to go and claim your 2 CPD points. Also just a reminder that the full webinar was recorded or still being recorded. The recording and the presentation will be made available to all our members as well as to Specialized Exhibition and be distributed through Electra Mining. Huge thank you to Electra Mining for this initiative for this whole week. This afternoon, there's another webinar on PPE. I think it's the correct selection on respirators. So you guys might want to quickly go onto the Electra Mining website and register for that one if you haven't done it yet. That will be presented or hosted by Sapema. Just then also in final conclusion, any of the other webinars that SIOS has hosted during this COVID period is available on our social platforms, our website, as well as our Facebook page. Please be on the lookout for the next one. We will continue hosting these webinars and also OHS seminars. And then in final conclusion, just thank you to Gareth, our technical guru at the back there. As per usual, touch wood, you know, the SIOS webinars has always been very professional from start to end, and we like to keep it like that. Thanks to Gareth. And then just a round up to our panelists this morning or this afternoon already. Garth, thank you very much. Really appreciate it. What an honor to have you on board as a chartered member of SIOS and for you to always share your knowledge with us. Thank you for not only the presentation, but the effort that you've put in this position paper with you and Dr. Q, which we've already circulated to our members, by the way. But it's one thing to circulate the paper and another thing to discuss it. Really appreciate it. Dr. Q, to you, thank you very much. Much appreciated. Nice to see you again. It's been a while since you did that excellent presentation at our conference. I think it was last year or a year and a half ago already on marijuana in the workplace. It was well received, that one. Thank you for that as well. And thank you for your participation this morning and this afternoon. And then Sean, last to you. Thank you. Well facilitated questions. We really appreciate it. Gents, thank you very much. Have a safe afternoon until we meet again. Cheers, everyone.
Thank you so much.